Good day, I'm Dr. Victor Tatko from Fatima University Medical Center in Antipolo, and I'm here to give a short lecture on the pathophysiology of direct hyperbilirubinemia in obstructive jaundice. I have nothing to disclose. Clinical jaundice refers to the yellowish staining of the skin, sclerae, and mucous membranes with the pigment bilirubin. It is detected when blood bilirubin levels rise above 2.5 to 3 milligrams per deciliter. Jaundice in general can be caused by a wide range of benign and malignant disorders. Among these causes, biliary obstruction is a common problem facing all general surgeons. Oftentimes, we discuss obstructive jaundice, and when asked how direct hyperbilirubinemia occurs, we always hear the answer, it is due to the backflow of bile to the bloodstream. The question is, do we really know the specific details of this process? This is now the purpose of this lecture to explain the pathophysiology of direct hyperbilirubinemia in obstructive jaundice. Let's begin with a review of the anatomy of the biliary tree. Bile is secreted by the liver cells at a constant rate of about 40 ml per hour. More or less, daily bile secretion reaches around 750 to 1000 milliliters. When digestion is not taking place, the bile is stored and concentrated in the gallbladder. Later, it is delivered to the duodenum. The bile ducts of the liver consist of the right and left hepatic ducts, the common hepatic duct, the common bile duct, the gallbladder, and the cystic duct. If we look closer at the liver lobule, hepatocytes can be seen arranged in plate, along which blood flows from the portal to the central veins. Within these plates, the small apical domains of adjacent hepatocytes form a tubular lumen called the bile canaliculus, which is the site of bile formation. From the bile canaliculus, bile flows to the small bile ducts and the subsequent larger bile ducts. This is another image of the bile canaliculus. You can see here, bile ducts are lined by a columnar mucosa with numerous mucous glands. Remember that all cells like the hepatocytes and bile duct cells are attached by tight junctions. The interlobal ducts join one another to form progressively larger ducts, and eventually at the porta hepatis they form the right and left hepatic ducts. The right hepatic ducts drains the right lobe of the liver, and the left duct drains the left lobe, caudate lobe, and quadrate lobe. The right and left hepatic ducts emerge from the right and left lobes of the liver in the porta hepatis. After a short course, the hepatic ducts unite to form the common hepatic duct. The common hepatic duct is about 1.5 inches long and descends within the free margin of the lesser omentum. It is joined on the right side by the cystic duct from the gallbladder to form the common bile duct. The common bile duct is about 3 inches long. It can be described into several parts, namely the supraduodenal, retroduodenal, and retropancreatic bile duct. And it ends below by piercing the medial wall of the second portion of the duodenum. It is usually joined by the main pancreatic duct, and together they open into a small ampulla in the duodenal wall called the ampulla of Vater. Please take note that the normal common bile duct diameter is 6 mm. Measurements above 6 mm denotes dilatation caused by a possible obstructive pathology. Also, the biliary system normally has a low pressure of about 5 to 10 cm water. Let us now proceed with obstructive jaundice and how direct hyperbilirubinemia occurs. Post-hepatic causes of jaundice are usually the result of intrinsic or extrinsic obstruction of the biliary duct system that prevents the flow of bile to the duodenum. Intrinsic obstruction occur from biliary diseases including choledocholitiasis, biliary ascariasis, benign and malignant strictures, cholangiocarcinoma, and disorders of the papilla of Vater. Extrinsic compression of the biliary tree is commonly due to pancreatic disorders. Patients with pancreatitis, pseudocysts, and malignancies can present with jaundice due to external compression of the biliary system. Finally, surgical complications can cause extrahepatic cholestasis. Misadventures with surgical clips and inadvertent injury to the biliary system can result in obstructive jaundice. Imagine a choledocholitis causing complete obstruction of the common bile duct. Bile cannot pass to the duodenum, followed by buildup of bile contents in the proximal biliary tree. Again, the biliary system normally has a low pressure of 5 to 10 centimeter water. When there is obstruction, the biliary pressure increases up to 30 centimeter water. This increased pressure causes dilatation of the biliary tree. As pressure increases, the tight junctions between liver and bile duct cells are disrupted, leading to increased bile duct and canalicular permeability. Due to this bile duct and canalicular permeability, bile contents can freely reflux into the liver sinusoids. Hence, conjugated bile reaches the bloodstream as it drains to the hepatic veins until it reaches the inferior vena cava and systemic circulation. This explains the direct hyperbilirubinemia in obstructive jaundice. Furthermore, leakage of bile leads to a marked inflammatory response into the portal triads, leading to structural effects, which eventually leads to liver dysfunction. That is why indirect bilirubin also increases in cases of obstructive jaundice. Aside from hepatic dysfunction, biliary obstruction produces widespread systemic effects such as renal failure, cardiovascular impairments, nutritional deficiencies, bleeding problems, infection and wound complications, and their perioperative mortality is higher. In summary, we briefly talked about the anatomy of the biliary tree and causes of bile duct obstruction, and we discussed how direct hyperbilirubinemia occurs in obstructive jaundice. Again, whenever there is biliary obstruction, bile duct pressure increases, causing increased bile duct permeability, leading to backflow of conjugated bile to the blood circulation. This ends my short lecture. The following are my references. Thank you and have a pleasant day.